Our next speaker is my colleague from here at Washington University, Soe Mar, who's an extraordinary pediatric neurologist. And her task is to describe what it's like to be a frontline pediatric neurologist diagnosing and managing patients with presumed pediatric acute onset neuropsychiatric syndrome. So.
Hello. I hope everybody is awake still. I was a little getting tired earlier on. So, okay. I can see myself that I'm probably the smallest among the speaker and soft-spoken. So if you cannot see me or hear me, and put your hands up. I'll try to speak up. Okay. So I normally run the demyelination, pediatric onset MS and demyelinating diseases, and also autoimmune encephalitis patients. So, that's part of I do all day long, and also I do have some research in these areas. So I'll try to describe as much as I could as a pediatric neurologist, how do we solve these problems. Streptococcal infection is actually very dear and near to my heart. Actually, I say literally because I grew up in Myanmar. I had rheumatic fever as a child. And so I almost had carditis. I'm not sure whether I really did. My doctor at the time advised me not to do any exercise. He did EKG. I mean, luckily, I received penicillin, actually monthly injections. And for 10 years, my mom was pretty adamant about it. So anyway, so I might have had a little bit of OCD. I'm not sure. My mom thought so. I think it did not do any harm to me because I became a child neurologist, which you need OCD a little bit. Oops, okay. That's what I'm talking about. I'm too short that it doesn't fit. Can you hear me still? Okay, good. So I do not have any disclosure. So the objectives of my talk would be for you to be able to understand the different spectrums of presentation of the pediatric acute onset neuropsychiatric syndromes. I'm not just talking about PAN syndromes. So that's what we see in general practice when we see. And also to formulate different diagnoses and management strategies. So as a child neurologist, we do see kids coming with the acute neurological symptoms and signs, and psychiatric symptoms and signs, and movement disorders, and sometimes they are associated with the encephalopathy or encephalitis. So I try to differentiate or classify them, and as best as I could when I see the child, when I evaluate the child, to see what sort of neurological symptoms, cognitive symptoms do they have? What sort of psychiatric symptoms do they have? Also, what sort of movement disorders do they have? And then lastly, but most important thing is, how worried I should be about this child acutely. So do they have encephalopathy, encephalitis features? This is the most important thing when I think about the child, when I see the child, how sick are they? Do I need to be very worried about them? So in terms of neurological symptoms, they can have seizures. Oops. Oh, it doesn't go off. Sorry. Back. Up. Can you get it back?
Just click in the middle of the screen whenever it does.
Okay. It's done. That's okay. Okay, good. There you go. Okay, so they can have seizures. They can have decline in school function, and children can present with memory loss, psychomotor slowing. Or they can have severe insomnia, language speech impairment. They can also have motor weakness, difficulty in walking, poor coordination. And when you do the neurological exam, some of them may have focal abnormal neurological findings. And they can present with the psychiatric symptoms. So these could be emotional behavior changes, confusion, disinhibition, depression, anxiety, and thought disorders. Sometimes some of them may have delusions, auditory or visual hallucinations. In severe cases, some may have catatonia, or obsession, compulsions, aggression. So we talk about neurological symptoms, psychiatric symptoms. Now they can also present with movement disorder. So they can have chorea, tics, dystonia, dyskinesia, automatisms, or stereotypies. Then they can also have encephalopathy. So encephalopathy, that term we loosely use sometimes, but actually we should, for the sake of the doing consistency, and there are very well classified criteria for encephalopathy. You need to have altered or reduced level of consciousness and change in your personality, behavior, or confusion. That needs to last more than 24 hours. And children can present with just lethargy and irritability that can be the sole features, and they can be called encephalopathy only if they have EEG features suggestive of encephalopathy. So generally, if you want to call encephalopathy, which means that your kid is really sick, that means that they have to have an altered or reduced level of consciousness and change in personality or behavior. So that's a little different from encephalitis. So encephalitis in term is encephalopathy with two of the following features: fever, seizures, focal neurological signs, or CSF pleocytosis, or EEG slowing, or MRI findings suggestive of encephalitis. So these are the criteria used for epidemiological infectious studies. So when we deal with the children with acute neuropsychiatric disorders presenting with either psychiatric, neurologic, movement disorders, together with or without encephalopathies, we need to have a broad differential diagnosis. We are in the frontliners as a child neurologist. We don't want to miss treatable, very serious disorders. So first thing we think about is infection and para-infectious process. Then next thing is, could it be autoimmune-mediated encephalopathy or encephalitis? Of course, younger children, particularly like 3, 4 years old, they might not be able to describe they had trauma, either accidental or non-accidental trauma. Could be seizure-related. Could be related to the toxins they suggested we didn't know about. Or could be metabolic disorders. Like as a child neurologist, a young child coming acutely sick, we always think about metabolic disorders. It could be urea cycle defect, ammonia, hypoglycemia, liver failure, or other amino acid, organic acid encephalopathies, mitochondrial disorders. It could be hypertension, hypoxia, hemorrhage, malignancy. This is a huge differential diagnosis. As a child neurologist frontline, we always think about wide differential diagnosis and then try to rule out in our mind that that's what is the most likely diagnosis and try to rule out many other things. Not necessarily you have to do that all the test, but I think every child we evaluate, we always go through the big differential diagnosis. Then we start thinking about how do we approach them. So I try to separate a little bit between the two slides, but in reality is actually there is a very fluidity between the two. Okay, it doesn't work. So, oops, went through already. Okay. So on the left side, there's an encephalopathy present in the majority, and right side is encephalopathy absent in the majority. But you can argue either way that some of the kids might be very sick and go into this, or some of the kids might belong to this group. But if you have a tics and OCD present in the majority, then you think about pandas, PANS, syndromes, chorea. Usually these kids not necessarily as sick as other kids. When you have encephalopathy as a majority with the movement disorders, we always think about autoimmune-mediated encephalopathy, which usually NMDA receptors is one of them. I think since 2007, since Dr. Delma described NMDA receptor encephalitis, we noticed that there are more and more cases coming up. Most case series are described. Now recently, based on the data, this is one of the most common cause of the encephalitis in children and adults. So usually, NMDA is more common in adults than children. They present with acute change in mental status, sometimes just acute psychosis, behavior regression, movement disorders, and usually they are very sick. Then another autoimmune-mediated encephalopathy, it's relatively rare in children, but we started seeing them because we're looking for them, is voltage-gated potassium channel complex. And particularly LGI1, they can present very similar to NMDA, but could be a little bit more subtle in terms of psychosis, behavior regression. They can have spells, look like seizures, but they're not seizures. Sometimes they can have facial brachial dystonia. So abnormal movements, initially people thought to be seizures. Basal ganglia encephalitis, another one, and subgroup actually has a D2 receptor antibodies, and they can present with severe movement disorders primarily, may or may not have a psychiatric features. And movement disorders are so severe, these kids are really sick. When you do the MRI, you can find the basal ganglion abnormalities. And GABA receptor encephalitis recently described in children. Not many cases being described, but it's been described in adults with a stiff person syndrome myoclonus. And PERM is a term used for progressive encephalomyelitis with rigidity and myoclonus. They can have anti-glycine receptors antibodies. These children or adults present with a severe stiff person syndrome or myoclonus. And we noticed that some patients have a same clinical presentation, but they can have two antibodies sometimes. So that tells us that sometimes antibodies alone doesn't tell us the story. There are few antibodies can present in the same patients. The same with we noticed that recently, based on the literature, for example, you have a herpes simplex encephalitis, and later on you can have an NMDA receptors antibodies. So I think it's important to keep an open-minded. By having one antibody doesn't tell us the whole story sometimes. Then, of course, we should not forget about the other disorders can give you movement disorders and also neuropsychiatric features. Lupus, our old friend, and also drugs, on teenagers particularly. You think about doing the drug screening. And most importantly is infection. We don't want to miss the infection. So usually EBV, mycoplasma, HIV, measles, you need to think about that. And again, acute disseminated encephalomyelitis, also known as ADEM, can have these sort of features. And rarely we will stumble into Wilson disease. So these slides show us the clinical features comparing between the antibody positive and antibody negative encephalopathy. I have a feeling that in about 10 years down the line, this is going to be useless because we're going to identify more and more antibodies. We'll have a better understanding of what these antibodies mean. So I think that emergence between the antibody positive encephalitis and negative encephalitis will become very blurred. But for the time being, what's being described is if you have antibodies positive, they tend to have more MRI abnormalities, EEG abnormalities, or CSF abnormalities. And the rest is not quite predominant, quite significantly different. But antibody negative group tend to have associated infections. This is a very busy slide, but I think probably one of the most important slides in terms of how do we evaluate these children. I put it this based on my own evaluation. So some people may feel a little bit different, but I feel that it's probably most of the child neurologists would agree with what we do. So any child presenting with primarily with the neurological and psychiatric symptoms, if they have a movement disorder without encephalopathy, the child is not sick, just have a movement disorders, we tend to look at their streptococcal, anti-DNAs, anti-nuclear, lupus, anticoagulant, thyroid function, comprehensive drug screening. If they are sick, if they have encephalopathy, then you need to do imaging study. You need to do brain MRI with and without contrast. And also we do lumbar puncture after the brain MRI. So in lumbar puncture, we look for cells, protein, glucose, that's usual standard testing. Then we look for any evidence of autoimmune diseases. So we look for IgG index, oligoclonal bands, neoterine. Then we test for autoimmune-mediated encephalitis panel. Depends on what we think is the diagnosis, we can narrow it down or we can do the panel. We can also test for the serum testing, the same with the autoimmune encephalitis panel. Also, we don't want to miss easy treatable metabolic disorders, so we can do CMP, ammonia, depends on the presentation. If you're worried about metabolic disorders, we do these. And CRP, ESRs usually give us a little bit of help in terms of is there any inflammatory process actively going on, so we do these tests. Of course, if the child has the features of encephalitis, then we need to go through the whole list of testing for the virus and bacterial. So bacterial, viral, PCR in the blood and CSF, nasopharyngeal swab, and serology. We generally test for HSV, HHV6, Epstein-Barr virus, parvovirus, mycoplasma. Then, depends on the season, what infection you're dealing with. You may test for influenza, parainfluenza, adeno, West Nile virus, enterovirus. And then, based on the exposure, you may do other tests. So this is the panel from Mayo Clinic. Dr. D mentioned briefly about it. So quite a comprehensive panel, but it's not complete by any means. Then, how do we treat them? Of course, the treatment depends on the etiology, their symptoms and their signs, and their severity of the illness. Again, I repeat the severity of the illness. The child is sick, we get very worried about, we do a lot of invasive treatment. The child is well, then I think, as Dr. Sweeto mentioned, mild symptoms that you don't need to do anything sometimes. So psychiatric symptoms are one of the most troubling symptoms in this population, particularly if they present acutely with encephalopathy. A lot of the time, we need help from child psychiatrists to deal with these children. We treat movement disorders based on their symptoms. We also treat presumed infection. If you find the tumor, remove them. Yeah? So going back to previous slides, actually, I did not mention about it, but as you see, there's an ultrasound of the abdomen. If you're worried about paraneoplastic syndrome, sometimes we do the MRI of the abdomen and chest. If you're worried about paraneoplastic syndromes or NMDA receptor encephalitis, and then a lot of these kids may have seizure, you do the EEG. So general rule for us, when you see the patients with the features of severe encephalopathy or encephalitis, we treat with broad-spectrum antibiotics intravenously first. While waiting for the other test, we also start acyclovir at the same time. Then, while you're waiting for the test, if you start suspecting that para-infectious process is likely, we use IV steroids, immunoglobulin. If you suspect that autoimmune process going on, sometimes we consider plasma exchange on the top of the steroids and immunoglobulins. In the same time, we need to treat seizures, other causes like toxins, hypertension, depends on the etiology we look for and we try to treat. Then, if the diagnosis is confirmed or highly suspicious for autoimmune mediated encephalitis, we start considering second-line treatment, particularly if you feel that symptoms are progressive. We use rituximab, cyclophosphamide, things like that. So now, given that background, I'm going to present you with the 3 cases. I'm going to take you through how do we approach these cases as a child neurologist. So actually, these first case we saw about 6 months ago. Some of my residents might recognize her. So she's a 14-year-old girl, previously healthy kids, presenting with altered mental status. She had cold symptoms. She had a little bit of joint pains for the past 2 weeks. Then about 10 days before the admission, she kept complaining about anxiety. She did have a little bit of baseline anxiety, according to the mom, but it was not severe. Then she was worried about upcoming science tests. She's a straight A student. So she kept repeating everything what her mother was saying. And then she started losing sleep, could not sleep well at night, stressed out about school, extremely agitated over the time, started yelling, screaming, inconsolable. So about 3 days before the admission to Children's Hospital, she went to a psychiatric outpatient facility as advised by her pediatrician. In the outpatient, she became very violent, started banging on the walls, took 12 people to restrain her. Then she calmed down, she expressed she was anxious, then she reported she was hearing voices. Then she was talking to herself. When you ask her, she said she was talking to Jesus. Then, so she was admitted to the inpatient psych facility at that point, and because she was so agitated that she received multiple medications. Then became worse. Then at one point she tried to put her head in the toilet, and she received more and more medications. Then became sick, went to the ER, because she became very tachycardic and hypertensive. She could not walk, very unsteady, and she stopped eating. She would refuse to eat. So on exam, she was awake, wide awake. She opens her eyes, but does not follow any commands. She does not respond to voice. She does not respond to touch. Then suddenly she started laughing uncontrollably. She would not respond, pull herself out of the painful stimuli, and she made loud noises, sometimes started barking. She had intermittent eye deviation, facial twitching. Then she had waxy flexibility at times, catatonia, and she does not respond to threat. She had hyperreflexia and clonus. So this is catatonia, waxy flexibility. So when you think about this diagram, going back to the diagram, how we approach, now you are dealing with the very sick kids, encephalopathic. So we are looking at this right side mainly. Maybe left side of the diagram may play in, but most important thing is this kid needs to be imaged urgently, need to do the spinal tap after the imaging. Given our story, we actually are very suspicious of NMDA receptor encephalitis, so we went ahead and do the ultrasound of the abdomen on the same day. So I'll take you through what we did. We did the MRI. Her MRI showed that there was an increased T2 flare, increased hyperintensity in hippocampi, and lumbar puncture was normal. We did ultrasound, showed right ovarian teratoma. So we did not send for any other test in her case. We just sent straight for NMDA receptor antibodies to our own lab, and serum was negative, CSF came back positive. We got the diagnosis within a few days, actually, and her tumor was removed within 2 days. She was started on plasma exchange. So I think diagnosis was made within, I think, about 4 days after the initial admission. So she received airway breathing circulation support, intensive care unit, she had plasma exchange, IV steroids, removed all the tumor, and then it went into intensive neurorehabilitation. And about, you would have thought like she should get better straight away, but she did not, even though we made the quick diagnosis. It took her a long time to recover. After about a month, really her recovery is slow, so we decided to start on rituximab. And we weaned her steroids slowly. She was an inpatient for about 2 months. Then, saw her in the follow-up 4 months. She's back to school, doing very well. In regular class, she's not a straight A student, struggling a little bit, but she's getting better, getting there, and she starts playing her favorite basketball game. And she had a normal neuro exam. So this is example 1 kid. I have 2 more kids. I'll present briefly before I end. Okay. So case 2 is a slightly different story. So he's a 15-year-old boy who had a history of juvenile absence seizures, diagnosed 2 years ago. He was treated with Depakote. Initial seizures were staring and generalized tonic-clonic seizures, but well controlled. He was seizure-free for about at least 6 months, actually almost a year, I think, before he presented acutely with a change in mental status and increase in seizure frequency. He started developing staring spells, increasing seizures, and he described that, his mom described as he was like very fearful and raised his arms, his eyes were wide open, and during the spells, he will hyperventilate. And he also had a shoulder and trunk stiffening, and sometimes almost like a dystonic position Mom was describing, he is flushing. And also, he has not been doing well at school over that 6 months. Then seizures got worse, he became more aggressive, more behavior problem, running away from home, increasingly anxious, could not sleep at night. Initially, people thought that's probably due to the seizures, maybe medication side effects, so multiple EEGs and video EEGs. It shows some evidence of spikes, sometimes slowing. But interestingly, these recent spells, particularly with the facial shoulder dystonia type, at the time we thought were seizures, were not seizures. They did not have any EEG correlates. So for the clear seizures, adjusted the medication quickly, escalated one after another. So he was on niacinamide, lamotrigine, clobazam, VNS, felbamate. And then he did not get better with these medications, just kept getting worse over that few months. He had delusion hallucinations. So on exam, on admission, he had very slow mentation. It takes such a long time for him to answer the questions. The most striking thing was how slow he was in his mentation and answering questions. And he had difficulties in calculation. So if he was a 9th grader, a straight A student, he can't add 2 and 2, but he's awake and alert talking to you, but very slow. Poor attention, poor naming, and slow movement, slow balance. So he's the one of the kid on this side with the obvious encephalopathy, but not as sick as other kids. So we started with the MRI. MRI showed that there is some cortical thickening, blurring of the gray-white junction. We think this is the probably congenital focal cortical dysplasia. We did not think that explains his acute symptoms. Went ahead and do the spinal tap. He had high protein, 46, which usually indicates there is an autoimmune process going on. So we went ahead and imaged his chest, abdomen, testes, they were all normal. And we did the autoimmune encephalitis panel to Mayo Clinic and came back as voltage-gated potassium channel antibodies were high. So he did not need intensive treatment like the first kid did, but he did receive IV methylprednisolone, IVIG, and then followed by rituximab, seizure treatments, and psychiatry input. So 3 months after the diagnosis and treatment, his seizures were better. He did not have any seizures for the last 2 months. His neurologic cognitive symptoms are slowly getting better, but still have a significant slowing, and he still has psychiatric symptoms. So I think the reason he recovers slowly is I think he was diagnosed a little bit much later than our first kid. So last case is a case 3. She's a 6-year-old, very, very cute little girl. And his mom came to me as an outpatient because she was having abnormal movements for 2 months. She had head shaking, tongue sticking out, tongue rolling, abnormal mouth movements, deep breathing, complaints about headaches. She did have anxiety symptoms and OCD symptoms before she got sick, but they were very mild. There is also a strong family history of OCD. Then her symptoms got worse. She refuses to go to school. She hand washed about 30, 40 times a day. She has to close the door several times. Actually, that's the cute thing was she has to hit her little brother, 18 months old, 4 times. Whenever she hits him, she has to do 4 times. She cannot stop otherwise. So also she was reading very well before and just recently could not read anymore. She makes a lot of noise when she reads. On exam, she was very anxious, but she was awake, alert, cooperative, and she was a little hyper. She answers my questions, she follows my commands, but she did clearly have chorea movements. So I think she more belongs to the left side in a way that it doesn't have encephalopathy. It's not as sick as other two kids. So I started with our usual movement disorder type, and then she did have anti-DNase antibodies were pretty high, diagnosed with Sydenham's chorea, treated with penicillin, checked for the cardiac problem, treated her anxiety and tics, and offered to treat her movement disorders, chorea, but actually mom declined because she already was getting better in about a month down the line. So just needed treatment for tics and anxiety. I followed her for 2 years at this point, and she's doing very well at school now, still taking penicillin, and she's on medications for anxiety and ADHD, still having very mild tics, anxiety off and on, but overall she's extremely functional. Okay, so I'm going to sort of summarize. This is pretty much like what we do as a child neurologist. So try to have a different spectrum of the presentation and try to understand, have a broad differential diagnosis and early treatment, early diagnosis and early treatment to make a better prognosis. I want to end with the slides. It's not a kid, but it's written by a reporter, Susan Cohen, and the name is Brain on Fire. A lot of us probably have read that book. The reason I like that book is actually a lot of our kids could not describe to us what they feel like as a patient, because these are kids, and these kids are very sick kids, but she is a very intelligent young lady, and she describes very well about what is it like to be like a patient who has encephalitis. Okay. Thank you.